Diseases of the thoracic cavity in dogs and cats. Hydrothorax, pneumothorax, and the diaphragmatic hernia. The differential diagnosis of pleural fluid accumulation. So diseases of the mediastinum. Mediastinitis, mediastinal neoplasia, and pneumomediastinum. Diseases of the pleural space. So you have pleural effusion, which can be divided into transudate, modified transudate, exudate, hydrothorax, pyrothorax, and chylothorax. Pneumothorax and diaphragmatic hernia. The surgeries are for hiatal hernia, traumatic diaphragmatic hernia, and chronic diaphragmatic hernia. So for the mediastinum, disorders are quite rare and they coincide with pleural disorders. You have to check the history, is there any trauma or foreign body ingestion. The clinical signs are dysphagia, regurgitation, and cough. So for the mediastinitis, this is the first disorder of the mediastinum. The causes are tracheal or esophageal perforation or infection. The clinical signs are head and neck edema, tachynoa, dyspnea, and cough. For the physical examinations, look for decreased lung sounds. On the radiographs, you can see focal or diffuse widening and pneumothorax or pneumomediastinum. The treatments are antibiotics, tracheal perforation, or esophageal perforation. The second disorder is mediastinal neoplasia. The origin can be a lymphoma or thymoma. The clinical signs are tachynoa and neck, head, or forelimb edema. For the physical examination, look for a dislocation of the heart. You must be able to recognize the heart easily. Or you can also see dyspnea, dull areas on the chest percussion, and in the radiograph, it's similar to mediastinitis. You see a widening and pleural effusion. The third disease is pneumomediastinum. This is air in the mediastinum. It's secondary to a neck trauma or subcutaneous emphysema or a rupture of the airways. The clinical signs can be tachynoa, dyspnea in the case of pneumothorax, or regurgitation in the case of esophageal rupture. On the radiograph, you can see radiolucency and air within the neck region. You can see air bubbles underneath the skin. And the treatment is, there can be a spontaneous recovery, or you have to treat the underlying disease like the rupture of the esophagus or trachea. And this is the most important part of this topic. So diseases of this pleural space. So the types of pleural effusions. You have transudate, modified transudate, and exudate. You have hydrothorax, which can be caused by hypoalbuminemia and congestive heart failure. Pyrothorax, which is from FIP and it's also known as pleuritis exudativa, and chylothorax and hemothorax, which can be caused by coagulopathy. So in pyrothorax or exudative pleuritis, it's caused by bacterial inflammation by obligate anaerobes like actinomyces or nocardia, both in cats and dogs. It's mainly by skin injuries, and it's reddish brown and has a grit-like exudate. In cats, it's with FIP, it's more of a honey-like colour. FIP is more likely peritonitis. Pyrothorax is diagnosed by cytology and culture. The therapy is thoracocentesis by chest tubing and catheterization for drainage. In chylothorax, it's caused by decreased lymphatic drainage. The diagnosis is thoracicocentesis and cytology. The therapy is thoracicocentesis and fix the underlying cause, like a low-fat diet. It can be caused by congenital, like weakness in the lymphatic vessels, idiopathic, non-traumatic, so there's disturbed lymphatic drainage, probably caused by right-sided heart failure, or traumatic, like a thoracic duct rupture. And you use triglyceride measurement to see if there's more pleural fluid than plasma. And the treatment is thoracicocentesis. The second disease of the pleural space is pneumothorax, or PTX. It's the air accumulation of the pleural space, and it can be traumatic, which is the most common through by blunt trauma, and you can also have spontaneous pneumothorax. It can be idiopathic. So the clinical signs are acute inspiratory type dyspnea and cyanosis, decreased lung and heart sounds, and there's a tympanic percussion sound over the when there's pneumothorax. The diagnosis, radiography is most important. It's obligatory. The ventral dorsal and dorsal-ventral are always recommended. The three diagnostic features are the heart is elevated and removed from the sternum, and there's an obvious demarcation in the intrathoracic organs due to the contrast effect of free air. And the third diagnostic feature is there's compression of the lung lobes. The treatment of pneumothorax is immediate bilateral thoracicocentesis, oxygen supplementation, and strict cage rest for 1 week minimum, and remove the tube if there's no air accumulating after 24 hours. In the case of traumatic pneumothorax, there's usually a rib fracture or airway obstruction. The treatment is to close the wound as soon as possible, perform thoracicocentesis, give antibiotics, and if stable, open the chest again and surgically explore the place for any obstruction. The third type of disease is the diaphragmatic hernia. So the abdominal contents enter the thoracic cavity through a congenital, acquired, normal, or abnormal defect of the diaphragm. The classification. So you have pleuroperitoneal hernia, which is purely hereditary. There's no wall between the pleural and diaphragmatic cavity. And the peritoneopericardial hernia. This is an opening between the peritoneal and pericardial sac. And the hiatal hernia. So this is when the esophageal or cardiac of the stomach go into the thorax. There's two types. There's a sliding, so the cardiac slips into the chest, and then there's the rolling. There's a wider than normal hiatus, and the fundus can go into the chest. The signs of a hiatal hernia are chronic regurgitation, vomiting, or anorexia. High-rise syndrome. So if there's a sudden or severe compression on the abdomen, you can have a rupture of the diaphragm, or alternatively, there can be a rupture of the lung lobes. The prognosis of a diaphragmatic hernia depends on the time of the anamnesis, the size of the hernia, so a bigger can cause less strangulation, but it can also allow more organs to get into the chest. And the organs can be dislocated, the liver is under the diaphragm, and the spleen is rarely ruptured. The GI tract is a major threat if strangulated. And the status of the lungs, usually alostasis, can be affected the lung lobes. The clinical signs can be mixed or inspiratory dyspnea, shock, cyanosis, stomach distension, and dog sitting position of a cat to alleviate inspiratory movements by gravity. Cats can also feel empty in the abdomen, a dullness, or asymmetric respiratory noises, or a lack of respiratory noises. This because the liver spleen can be covering, or there could be pneumothorax, and arrhythmia and respiratory acidosis. For diagnosis, radiography is so important. The thoracic cavity is covered in abdominal organs, especially if there's contrast. First, check the thoracic position of the organs, the lung pattern, and any free content in the cavity. And then check the diaphragmatic line, the liver, the stomach position, and clarify with a contrast. For treatment, you need to do surgery. Even if there's a silent hernia, signs are presenting months after an accident. Pressure on the abdomen during defecation or parturition. Barium sulfate outlines the localization. So for surgery, in a diaphragmatic hernia or a hiatal hernia, pull the fundus out of the chest and back into the abdominal cavity. To prevent reoccurrence, stabilize it with interrupted stitches, and also perform a gastroplexy to stop further dislocation of the stomach. In traumatic diaphragmatic hernia, it's an absolute indication for surgery. You need to stabilize the circulatory and respiratory status and correct the acid-base imbalance and sedate and perform a thoracicentesis. For surgery, use inhalation anesthesia, monitoring, laparotomy, and reposition the abdominal organs, evaluate the vitality of the organs, remove any necrotic tissues, and restore the diaphragm. In a chronic case, the dislocated organs are adhered, either to the diaphragmatic defect or to the pleural area. They stabilize themselves in this abnormal position. The lobes get used to being compressed by the abdominal organs and they take the shape of the remaining space provided for them, and this results in atelectasis. The abdominal wall gets used to the lack of abdominal organs and the contraction of the abdominal muscles, and the diaphragmatic muscles also getting contracted and gradually loses its flexibility. Overall, in a chronic case, the reposition is harder, there's a higher chance of bleeding, and the contraction means there's a difficulty reaching some organs, and you may have to lengthen the incision. The contraction of the muscles means you'll have to refresh the wounds in the edges. You'll have difficulty closing the cavity within its new capacity. There will be pressure on the suture line after the closure.